I was asked to talk a little bit about healthcare. They did ask me to talk about healthcare reform, but I want to try to avoid getting very much into the politics at all. I just want to discuss with you just some concepts that might put into perspective some of the things you've already heard and all of the things you're going to be doing the next day or two. Where does it all fit in? How do you look at a bigger picture of what healthcare could look like in the United States, and where is the role of innovation? What components might exist for opportunities for the kind of work that you have to come forward? And when I'm done doing it, I think you will see why healthcare reform is so important, that it be done right, because the work you're doing will have no meaning if there's no business model and there's no reward for it at the end when it's done. If we're paying for the wrong things, the work you do will really not be of much value to anyone, actually. Frankly, that's why I think we are where we are today in the country, is because nobody's really been looking for innovation. Nobody's been really trying to pull innovation forward and say, what value can we find in delivering care to patients in a new way, for instance, in their home? And when I give these talks, I start by asking the same questions, and some of you have heard it, so forgive me, I'll go through them very quickly. Who in this room would like to be admitted to a hospital tomorrow, even if it's the best hospital in the world? Are any hands going up? If anybody puts a hand up, please let me know, because I'd like you to explain it. If that's the case, why do we look at hospitals as the center of the universe for healthcare in the United States? Now, you and I know why that happens, because nobody's dealing with the questions I'm going to be asking you. Okay, who would like to be sick tomorrow? Nobody would like to be sick tomorrow. Who would actually like to ever be a patient? A patient is defined as someone who long suffers or long endures. Any hands go up for that? You've just answered 3 questions that need to be answered with your answer, no, no, and no, in a new model for healthcare in the United States. Because we know today there is a lot more we can do to help everybody in this country and globally be able to answer those 3 questions, no, and have a realistic expectation of attaining it. I know we're all going to die, we all might end up in a hospital at some point, but instead of being in the hospital 45 times in my life, maybe it's better if I'm there once. Somehow we have to figure it out. Our business models today in the United States say the more you're sick, the more medicine makes money. You just told me you don't want to be sick. So we need to take a step back and say, okay, and I'm going to take this through in the concept of a system engineering's approach, and it's really going to be a system of systems approach, and say, and I've made it simple to just make a few points. Let's look at healthcare in 3 domains very quickly. I'll try to go through them for you. If we break them up into 3 categories. Now, the first domain I've called the knowledge domain. It's the domain inside that universe, which is a system in and of itself. But just inside that universe are people who are doing investigation, basic research. They're looking at translational research. They're trying to develop new knowledge, new discoveries, taking that through, collecting the information around that, and trying to generate some new knowledge that is a result of these new discoveries. So if we look inside that domain itself, and I'm not here to talk about these smaller domains, I'm going to talk, as you'll see, about how they all interact with each other. But just take this one domain, look at that universe, and inside that universe there's all these dots, and they're all the academic medical centers. They are all the people who are doing research. They're all the scientific and research and development arms of drug companies and device manufacturers, etc. Tremendous amount of funding goes into this from the government as well as private sources and benefactors. Huge amount of money going into that domain. Inside that domain, if you just take a look at it, you will see some connectivity. That's what those little lines are. They're showing some of the nodes or some of the stars or locations inside that universe are connected, and they are consciously connected. They do try to connect with each other. Not very well, but they do try to relate to each other, one way or the other. CA Big is an example of an attempt to consciously, electronically connect discovery organizations together, if you will. So that's just one domain for you to be thinking about. The next domain I'd like you to think about is the care delivery domain. Now, in the middle of that universe should be the patient. And the patient is not even in that universe in today's models. Matter of fact, the patients are sort of like the way airlines look at all of us who get on the planes. We're self-loading baggage. And patients are the mechanism by which we all make money. They're not really the center of why do we practice medicine? Why do we do education? Why do we do research? If the answer is just to make money, then we can understand the way our system is functioning today. But if the answer is to take care of people, that's hard to understand, because people are not really being put in the middle of the care delivery domain. Now, when you look in that universe, we see galaxies in there. We see individual doctors. We see small groups of physicians. We see larger groups of physicians, maybe specialty groups. We see small integrated group practices with multi-specialty disciplines. We see large integrated group practices. We see small hospitals, large hospitals, individual hospitals, community hospitals, groups of hospitals, big hospital providers. We see academic medical centers, and we also see places like Mayo Clinic, which is a little of it all. Integrated group practice, it's got everything together, including the hospitals. When we look inside that universe a bit more, we can actually see that some of the galaxies actually have some connectivity. The connectivity, like Mayo Clinic or Geisinger or other places that have consciously built electronic records or have electronic communications, before they ever did it electronically, they were also integrated to begin with. By paper, or by telephone, or whatever mechanism, there were degrees of connectivity within a galaxy. But nobody is connecting the galaxies. There is no other connectivity there. I'm overstating the case. There are a few communities that are relatively well connected, like Winona and other places that have a well connectivity. But they prove my point, that there hasn't been a conscious attempt to get the connectivity done. There's talk about it now with David Blumenthal and the National Organization for Healthcare Information Technology, the Office of National Health Information Technology, ANJIT. Okay, then we look at the third domain here, is the payer domain. Now in that domain, when you look at that universe, the more I've looked at it, the more it just looks like and feels like the Big Bang has just occurred. There's total chaos inside that domain. You've got individuals who pay out of their pocket. There's Medicare, there's Medicaid, the US military system, you got the VA system, you got TRICARE, S-CHIP, you have private insurance of all types, Federal Employees Health Care Plan, you have self-employed insurers insurers that self-insure. It's just complete chaos. There is no singleness that I can find anywhere. We submit forms that are totally different for each insurance company, but the worst part of all is that the payment that takes place through that payer domain has no linkage whatsoever to anything we really want out of healthcare. There's no linkage of payment to outcomes, to any safety parameters, service parameters, as a general statement. There will be exceptions. The exception could be a place like Geisinger or Intermountain or Kaiser that have their own insurance company, so that they basically have the payer domain and the care delivery domain linked together in one unit. So they can streamline a lot of this stuff, and their payments probably are oriented around some degrees of patient satisfaction, good value, etc. But the general rule, we have those three domains. I'm not here to talk about the three domains. I'm here to talk about what systems approach would say if you have complex, and that's what these are, interdependent systems, and that's what they are. The key is managing at their interfaces. What goes on at their interfaces and how they interact with each other. And that's where the country has lost everything. This is my personal opinion about it. When we look, if we take a complete systematic look now around those three domains, and there are other domains, by the way. When I talk to physicians at the AMA, I have a whole other domain on legal. I'm just making this as simple as I can. So let's just take a look at those two interfaces between the two groups. The first interface on the left is that translation interface between the knowledge domain to the care domain, and in there is a translational interface. Something should flow through there so that new knowledge comes out, we find the incremental value that it is brought to patients, and we apply it in the care delivery domain. Because of the current way this interface is managed, the results are these. We have lots of great ideas coming out of the knowledge domain. It's flooding out all the time. It hits some kind of a barrier. Sometimes it's the FDA, but it hits some barrier that doesn't really know how to analyze and try to get to the conclusion of where is true value for this new discovery. Instead, we put up barriers that have huge hurdles for people to get through. And what happens, the price we pay, is that the data seems to indicate that on average, in about 17 years, a few good ideas get out into the care delivery domain and are applied appropriately 50% of the time. On average. 17 years, 50% of the time. The removal of beta blockers from the standard measurement of good quality care just occurred, I think, this year. That was a 25-year process to get people to use beta blockers appropriately at a high enough level that we're stopped measuring it. That's quite an indictment for a system that's supposed to be very good. Well, everyone says the fact is there is no system. That's why we're having trouble. It's not that the system is broken, there is no system. Nobody ever tried to design something along the lines that I'm challenging people to think about. On the other side, we have a whole bunch of ways to care for people. I call them products. Ways to care for people, here, there, everywhere. Some of them are really great, like taking care of people at home. Try to get paid from Medicare to take care of people in their house, to keep them out of the hospital, and use non-traditional providers. That'd be called fraud. You get paid only if the patient's sick and they come to your office. Matter of fact, they only get paid if they come to your office. So we have to change the way we think, and there's a number of good products that come out, but they sort of die because there's no reimbursement. And I know this to be true. We tried it in Jacksonville. I've had several experiments with it, and we have never been able to sustain it because we can't get a business model that somebody will say, hey, this is a value we want to pay for it. It's not in the traditional thinking of how we get reimbursed. But then on the other hand, some things do get through the interface, and they come on out into the payer domain, and the length of those arrows correspond to how much you're paid in relationship to your costs. Many things are underpaid, a few things are overpaid. But the worst part of it is, it depends on the payer. Totally unpredictable until you get down to your contracting. But one payer may be actually overpaying you for certain uses of certain technology than what you would really need to get paid. And others are underpaying you, and it's totally unpredictable, and it varies site by site, and in our own institution it varies depending what state the patients go to. No rationality at all brought to this. So as we talk about this kind of a system, where can we begin to think about how the work you're going to do might have some impact? And I think there are many people here that span the whole spectrum. Some of you may live a little more down on the left-hand side, a little more at the basic research or the knowledge generation domain for maybe care delivery. Some of you may be right there where the patient care is, maybe in the business side or in the practice side, but you're right kind of in that location. Probably all of you somewhere along the line are affected by the interface on the right, one way or the other. You have to deal with that. And I don't know who all is in the audience, but there may be some people here from payers that sit in that right-hand side. I'm not really sure. There are some strategic priorities now that have arisen through work within Mayo Clinic and through work through the Mayo Clinic Health Policy Center that I think will relate to what you're talking about. I'm going to show you where these cornerstones or strategic priorities might fit into our thinking. And these are terms that you are hearing today around the country, and I'll just throw them out because all of you may be somewhere among these terms. The first would be these four that I threw up at one point, and I'll go over each of them for you. These are the four strategic priorities of the Mayo Clinic. And let me take you through them right now. The first one, way on the left-hand side, is the concept of individualized medicine. it has two components to it. One is the real focus on the individual. Just that concept in and of itself is an important one, in my opinion. People talk a lot about improving public health. You cannot improve the health of a population. The average health of a population cannot be improved unless you improve the health of every single person in that population. The Gates Foundation has found this out. They have the vaccines, but somebody has to give the shots. To get 100% population injected, somebody's got to give the shots, and it's got to be one-on-one. You cannot fix the population of diabetics by wishing for it or hoping we have a group of people who can actually take care of, well, we'll take care of 98% of the folks, and we can't get these, so let's ignore them. What we need to do is have a new way of thinking of caring for people like Intermountain does, and the people in the Twin Cities at Health Partners, when they focus on diabetics. Intermountain's got 25,000 diabetics in their health plan. They have 4 endocrinologists who don't see patients. They orchestrate the care for every one of those 25,000. Now, most of those 25,000 fall into buckets or in bins, but there could be hundreds of bins. So that if it's a 60-year-old pre-transplant with diabetes, they're getting one kind of plan. If they're 52 and have had heart disease and they're on insulin and they're overweight, that's another plan perhaps. If they're 40 and they have adult onset diabetes and they're overweight or not exercising, another kind of a plan. If they're in their 20s, it's something different. And if it's a 7-year-old kid with new onset insulin-dependent diabetes, whole different plan. So that somebody might actually be visiting that kid in the school. So they conduct the orchestra of care that is tailored for each person, and they have among the best outcomes in the country at the lowest costs. Highest value because they focused on the individual. That's real science. It's science of delivery, but it's real science. The second component of individualized medicine is what we all think about: personalized medicine, genes, proteins, novel diagnostics, novel therapeutics. Where is the incremental value that those discoveries will bring to the care of patients? And if you truly believe that genetics and proteomics say we're all different than one another, then individualized medicine is going to become ever more and more important, because the value will be not in does this new drug treat all of us in this room, but does this drug have a value for that table or for me alone? And can we identify the value so we do not throw the drug away because it doesn't work for everybody? That's individualized medicine. Nobody's talking about that politically. A lot of other people are talking about it, but there's no room right now in the political discussion about this concept. So individualized medicine is absolutely crucial for the future. Now, I place that way over there at the knowledge domain because this is a lot of research. It's basic research, it's developmental research, it's applied research, but I put it over there. But clearly, you can all see that it goes from the knowledge domain right into the care delivery domain. So I just threw these up to be as simple as I can, but it spans the whole place. Science of healthcare delivery is right in that translational phase, but it also goes over into the clinical side. The science of healthcare delivery is using engineering principles to figure out how to give better care for patients so that we get better outcomes, better safety, better service, and lower cost over time. And I mean every single component of engineering. And I'm not talking about just the hard science about monitoring people at home. I'm talking about process engineering, workflow engineering, queuing theory, the way we schedule appointments, the whole spectrum of operations research that's in engineering. Huge opportunity for innovation, and in my viewpoint, this is the biggest area for potential innovation to get better care for patients. Because I would submit having 98,000 medical errors per year is not excusable in this country. People will say, well, it's way too high. Some people say it's double that. Some people say it's lower. I don't argue that anymore. I say it's at least 1,747 crashing per year. And we wouldn't tolerate that in this country. But 98,000 people having drug errors is 1,747 crashing every day and a half in the United States. And we have no reporting mechanism at a national level that systematically looks at these errors and tries to systematically weed them out and improve care in the United States. It's a disgrace. We would not stand for that in the airline industry, but we just assume it in the healthcare industry. I don't actually understand it. But science of healthcare delivery should be taught everywhere in this country, having physicians learn how to work in teams with nurses, non-traditional providers, and develop ways to get zero defects. Better safety, better service, better outcomes for patients, and while we do it, you get lower costs. So it's been shown over and over again. That leads to the next one on the top, care delivery, create value. You've heard about value. And value, in our definition, is very, very clear. Our definition being Mayo Clinic's. It's the outcomes, the safety, and the service in the numerator. Those are the elements of quality, outcome, safety, and service, divided by the cost of attaining those outcomes over time for a patient. Not on a line item, but over time. It's measurable. Every one of those components is measurable. People wring their hands, fewer and fewer are wringing their hands about we can't measure quality, and that is bunk. It's totally measurable. And frankly, Medicare needs to get on with it, and we have proposed that they actually do it. And we said, in 3 years, Medicare should be paying for value. This is what we've asked for, because we've been asked to say, what do we really want? They should be paying for value. In 3 years, they should define value, begin to measure it, become transparent, and start paying for it. And you're going to say, well, that's really hard. How are they ever going to define value? It's simple. Take the top 3 to 5 medical conditions that are the most expensive in the United States. Just take 3 to 5 of them. That, by the way, covers about 60 to 70% of all Medicare spending. Just happens to cover that. You take their 3 to 5 top conditions. It's going to be heart disease, stroke, and say what outcomes you want. How hard is that? The safety is easy. Anybody who gets 0 errors is better than anybody that gets 1. That's easy to measure. And patient satisfaction is already being measured nationally. It's been published for several years. So you can start. We also said what they ought to do is look at procedures too. Take the top 3 to 5 most expensive procedures. For instance, in Medicare, it's hips and knees are the top ones. Let's describe some outcomes for those. How hard is that? But somehow, the creation of value has to be the responsibility of the care delivery domain. It rests right there, and we need to do that, and there's lots of room for innovation there as we look at it. And then the last one, the coordinated integrated care, is a high priority for Mayo Clinic. It is an issue that when we look at places that produce high value care, by my definition, there are several common characteristics. Not 100% common, but some characteristics that tend to come to the top, one of which is integrated and coordinated care. And there are 2 different concepts. Integration of care and the coordination of care around the patient. The integration is a little more specific to the delivery people, and the coordination is more specific to what the patient feels. Slightly different concepts, but related to each other, obviously. Those are Mayo Clinic strategic priorities. Now, in the last 3.5 years, a little more than 3.5 years, we've also had a Mayo Health Policy Center effort that has engaged over 2,400 people or more in it, including people from all the sectors of healthcare delivery, all 10 of them, and about 1,400 people who spoke for themselves as patients. Out of that process, we ended up with 4 cornerstones. And here are the 4 cornerstones that came up. The 2 in the middle, creating value and coordinating care, did come out of those discussions also. And I didn't lead those discussions. These were led by a different group of people. They weren't led by anybody. It was a free-floating process that had a deliberate attempt to prioritize and come to the top of leading priorities. But look at the other 2 that came up. Insurance for all, and I'll mention about the FEHBP in a minute. Insurance for all and paying for value. Those were 2 that came up, and the other 2 were creating value and getting coordinated integrated care. Now, just make a quick observation before I finish up. When you look at those two sets, the one in white on the left, the one in the one in blue on the right-hand side. The one on the left side were Mayo Clinic strategic priorities. If you look at Mayo Clinic as an integrated group practice academic medical center, it becomes understandable. Our priorities resonated around what we understood: the knowledge, the care delivery, and the interface between the two. That's kind of where we live. When you look at what the patients ranked, it's where they live. They have to deal with the payer, which drives a lot of patients crazy, and they have to live with the providers that drive the patients crazy. They live around that other interface. It was kind of interesting to see, and there was overlap, though, around the idea of value and coordinated care. And then the last comment I'll make about this slide is that where you see the federal employees healthcare model, that's an important point. Out of our deliberations with the folks that we interacted with, the preferred way to get insurance for all, just to make it clear to everybody, is a model like the federal employees model. What is that model like? If you don't know what it's like, all the federal employees have it, including all the Congress people and the president, the mail carriers, the CIA agents. They all have this, what I'm about to describe. They have an exchange. They have a menu of 157 insurance companies, some of which have multiple products that they can choose from. The government has a quality score and a rating score for them. Drugs have been covered for 40 years in this plan. There is a base product that the government, depending who they're working for, will say, here's what we're covering, and people can buy more if they want to. They can buy whatever product they would like to. It's transportable. They can take it wherever they go. And it becomes their secondary insurance when they retire and go into Medicare. And it's all private insurance. That's the preferred type of a model that our group, that we led through this, felt should be available for everybody in the country, that people can choose what they would like to have. The counterpoint was the debate around Medicare as the, quote, single payer. And the unfortunate fact is Medicare is not a single payer. Everybody thinks it is. Medicare is not a single payer. The government puts some money in. It's managed by private insurance companies. And I don't mean Medicare Advantage plans. I mean the administration on how we all get paid out of the payer domain is by private insurance companies. It covers about 50% of the costs. Until a year or two, it didn't cover drugs. And when it does cover drugs, it's through private insurance. And almost everybody buys a supplement or has it from their employer, which is usually a private product. So Medicare is progressively covering less and less as the single payer. So whatever it is, whether it's a Medicare model or a federal employees model, we're not here to fight that battle. We're here to say the most important point is that if all of you are working hard on the knowledge domain, at the translation interface, and at the care domain, creating value, if we're not paying for it, we're not going to get it. So our main message wherever we go is that true healthcare reform is paying for value. Health insurance reform is what everybody's talking about. Totally separate, nice little argument, whatever they choose, single payer, multiple payer, private payer, it doesn't matter. Whatever they choose, we have to get whatever that insurance company is or companies are to pay for value. Because if we don't pay for value, your work will not be aligned with the ultimate reason that most people are practicing medicine. And that's to get paid. That's a little blunt statement. I may be overstating it, but that's the way I look at it. If we want to change the delivery system, and you want to systematize what I've just described here, we need some lever that we can pull that will align the system to move. And that lever in that diagram is paying for value. If you align that lever, everybody on the left side will start to self-organize and find ways to create value and go after the rewards associated with it. We already know that from before because the fee-for-service model in Medicare that pays the most amount of money for the worst care has a lot of people going after fee-for-service in Medicare. We have, in 30 years, we have completely self-aligned ourselves to go after the payment model Medicare has in place today. If we can get Medicare to start paying for value, this country will change. And the final statement I will make is to get the country to pay for value in Medicare does not require an act of Congress. It doesn't require a debate nationally. Medicare is run by a board of directors called Congress. The administrator appoints, the administration appoints the people who run Medicare. It's totally in their power to tell Medicare to start paying for value in 3 years from now. No act of Congress is needed. This can be done overnight, whenever they appoint a CMS director. There's been no person running CMS, which is Medicare, since 2006. I don't know how many people know that. So that's why when we go to Washington, we do get crosswise occasionally, because I look at a lot of these problems being solved if Congress would stand up and take its own responsibilities, and the administration take its own responsibilities. So that's the systematic approach, and I hope as you see this, the work that you do to create innovation, to get better value, whatever you do and wherever you live and wherever you are taking care of patients, if you are producing better outcomes, better service, and having better patient satisfaction, and you're getting the cost down, or any components of that value equation, you are innovating, you're creating a better future, you're taking care of patients. The rest of us have a job to try to make sure that there's a way that you can stay in business while you're doing that. Okay, so I thank you very much right there, and appreciate all your attention. Do I take any questions or anything? No, we're done. Thank you very much.